So, good evening, all. Uh, Today, it's a practice session for all of us. So, you can see my screen, right? And I am clearly audible to all of you.
Yes, you are.
Okay, thank you. So, we will be discussing CVS case scenarios today. We have like three scenarios to be done today, and one will be a clinical case, another will be a communication, and the third one will be a video. So before we start our discussion, we are starting, I'll just let all of you be informed that we are starting a long course for Diet 3 students, which will be starting from September 2025 onwards. And this will be a long course in which we cover all the topics in details, all the stations will be covered in detail, and lots of practice is given for each of the stations. And this will be these will be small groups so that each one of us gets like ample hands-on practice. And this is our QR code. You can scan and join our group and get details for the course. So without wasting much time, we'll be moving on to our scenarios, which I just told that we will be doing. So it will be, first of all, it will be a clinical station. And we all are aware, in the clinical station, we just have to sit outside the station. And in the outside station, we just won't be given anything. As soon as we enter the station, our time starts. This time is of 6 minutes, in which we are given to the command by the examiner to examine the patient. And there will be, after 6 minutes is over, we will be told about it, and there will be a discussion about it in the next 3 minutes. In the communication station, we have 3 minutes outside, in which we are given a stem. We have to read that stem. And when we enter inside, we have 6 minutes plus 3 minutes in communication, in which we will be discussing for the initial 6 minutes. And after 6 minutes, a bell goes, in which in the last 3 minutes, we will be summarizing. So the communication will be 3 minutes outside and 6 plus 3, that is 9 minutes inside. Whereas in the case of video station, we have to just sit outside the video station. As soon as we enter, we will be given a video to see, and this video is basically given for us the time of 3 minutes in this case. And in this case of 3 minutes, like you can see, rewind the video multiple times, and after the 3 minutes over, the examiner will start discussion about this thing. Hope that this is clear to all of us.
Yes.
Okay. That's good. So for the clinical station, I'll just give a brief approach of like what important points we all are aware of. Like in any of the clinical station, as soon as we enter the station, we have, like, after we are given the command, we have to do our hand washing, which is very important. We have to introduce ourselves to the patient. We have to take their permission, and we have to engage the patient and keep on empathy with them. 4Ds are universal for any of the clinical stations, including the CVS, in which we will see, is the patient really distressed or is he like okay? Any devices which is nearby the patient? How is the growth parameters of the patient, the dimensions? Any features, dysmorphic features, if they are there, they have to be like noted. So there comes a question many a times in between the minds of the students, like should we verbalize like while we are doing the things, like is the patient distressed and all? So it basically depends on examiner to examiner. You can start verbalizing, but if the examiner asks you to stop, you can stop, and then you can do the things. And when you are summarizing the case in the last 3 minutes, then you can tell the things. So it depends on the examiner. Some of the examiners are okay if you keep on verbalizing, like, okay, looks dysmorphic with these features when you are doing. So that also works. So you should be prepared for both of them, basically. This is very important. Then moving on to the general examinations, the important things are start from the nails. You have to see for clubbing, and for the clubbing, we all know that classical sign. You don't have to touch the patient. You have to ask them to make this diamond. So that is very important. You have to comment on the signs of infective endocarditis. You have to see for the palms, for any Janeway lesions. You have to see for the tips of the fingers, for oscular nodes. And are the oscular nodes like tender or non-tender? Any one of you?
Tender.
Tender.
Yeah, they
Tendered.
are tender, right. That's very important to remember that they are tender. And then sphincter uprages.
मैंने headset काम ही नहीं कर रहा है। एक
Can you all mute your like mics?
Dr. Murtaza, you said not to touch the patient while seeing for clubbing. What I
Right,
practically
right,
some children, young children, they are not able to make exactly the yeah, how you would want them to do. So they need some
right.
help. So is
Yeah,
there
yeah.
anything wrong in like holding their hands and helping them do it?
No, there is nothing like wrong in
like
that,
wrong in
but there is nothing like wrong in that. The main thing is like prefer not touching them unnecessarily. If he is unable to do and you have limited time,
that.
so you can help him. That is there,
मैंने
but
पैरासिटामोल रात्रि
definitely
का
not do that. Like when you are seeing for pallor, icterus, at that time also you have to show in your like eyes how to do it, how to do it. Ideally, you should not touch it. If they are unable, then you can do, of course. That is like that will be different to the examiner also. I hope I made myself clear.
Yeah, yeah.
Yeah. So just go in a systematic fashion. The most important thing is like after you have seen the hands, the palms, go to the forearms, go for the arms. You have
बस
to
कान
tell
बंद
them
करती
you
हूँ हमेशा
can't
को
measure
डॉक्टर
the
टाइम से
BP
जितने
there.
होंगे इसको वॉक करके लेके जाएंगे सही रहे
Can you please mute off your phones?
ऊपर से नहीं आ सकते स्टोर में डालो
Need to see that.
कहाँ
So you
लाइट
have to go in a
हाँ जरा
systematic
लाइट लंबी
fashion,
चटवाते ना तो
which
मुझे
is
देखो
very
वो बड़ा
important.
हवा की
Dr.
सीने से
Seher,
बात
Dr. Seher, can you please mute your phone? Dr. Seher. Thank you. So we have to go in a very systematic fashion. So you started with the hands, softer clubbing, seen for any signs of infective endocarditis. Go on to the palms, move on to the forearms. You should, one thing in examination is very important. We should not be jumping from here and there. It should be in a systematic fashion. Even if you started from somewhere, which like we have been taught to start from our hands. Even if you start from your head, at least go systematically and then come to the hand. Don't just show like once you are seeing for the pulse, then suddenly jumping to the eyes, coming back to see for clubbing. So that won't work. So that will cut your marks. So don't go in a systematic fashion, and it should reflect that you know the things. Your sequence might change a bit, but it is always advisable that you make your own sequence rather than mugging up like something which has been given to you. Make your own sequence and practice on it multiple times before the examination. At least in the last 15 days, you have to practice all your stations systematically. So then you will move from the arms. Tell them that you would like to see for the BP. Normally, there is no time to see for the BP, but you have to tell them. Then you have to see the axilla for the signs of puberty. You have to see the side of the neck for any webbing. Head and neck, you have to see for the pallor. You have to see for the icterus, any polycythemia. Mouth, you have to see for cyanosis. How is the oral hygiene? Is there any high arched palate? That's very important. You have to see for any distended veins in the neck, and you should prefer seeing for like lower limb edema and all. The most important thing which I would never like all of you to forget is in the case of examination of the precordium, in the case of cardiovascular system, you have to examine on both the sides of the chest, because many a times dextrocardia will be there and you cannot miss this thing. Otherwise, whole of your examination findings will not be like matching, and you will get your marks cut off for them. So always put your hand on both the sides of the precordium to see where the apical impulse is, so that you can carry out your examination on that same side, and don't assume that the heart is on the left side. You have to examine the front and the back always. That is very important. Go systematically from inspection, palpation, percussion, and auscultation. Do it simultaneously. And before finishing, you have to say the things. In CVS, we normally say in order to complete our examination, we would like to check the blood pressures, JVP, pulse saturation, pulse in all the four limbs, I mean, the saturations, any hepatomegaly, if you have time, you should always see for. And if the child is in the pubertal age group, you have to tell about the Tanner staging. So this is like the basic gist, some summary of how to go about in CVS examination. I think the things are clearer as of now. So this is just like a slide in which we have been talking about the scars which are in the case of CVS. So what we have to remember in this case is most of the scars are midline sternotomy scar. All of the cardiac surgeries are mostly done from the midline sternotomy scar. Whereas if it is in the lateral thoracotomy scars, you have to think for either BT shunts. Remember this thing also, BT shunts can be done both from lateral and midline sternotomy. So it's not that if someone is having a sternotomy and you cannot tell BT shunt. Midline sternotomy scar can be from BT shunt also, but if it is on the lateral side, you have to think for BT shunt, you have to think for PA banding, pulmonary artery banding, you have to think for coarctation of aorta repair, that is very important. Whereas you have to think also for lobectomy, that is also important, which is there. PDA ligation also is done in those cases. So these are the scars which are like, if you see a scar, then you have to mention about the scar in that, and you should have something running in your mind. Like if it is a sternotomy scar, what should I think of? If it is a lateral thoracotomy scar, what all should run in my mind? So that's very important for the scars. So normally with regards to the common scenarios which are there, think of both congenital and acquired causes. So you have to keep in acquired, most common is rheumatic. So think of both of these and classify the things. If it is a congenital, classify them into two parts. You have to either take it towards a cyanotic. If it looks really non-cyanotic, then it is acyanotic, and either or cyanotic. So in the acyanotic, the examination cases which mostly are given are ventricular septal defect and PDA. They can be stenotic lesions in the form of aortic stenosis, pulmonary stenosis or mitral stenosis, or even coarctation of aorta. Whereas regurgitant lesions are mostly given MR and AR. Whereas if it is a cyanotic condition, most commonly given is tetralogy of Fallot physiology. So VSD PS physiology is the thing which you have to keep in mind. So it will be like you will get a ejection systolic murmur, those things. So VSD PS physiology, or it can be a Eisenmenger's physiology, or it can be a complex congenital heart disease. So these are the, like in a nutshell, the scenarios which are expected out of us. We are not expected in the case of cardiovascular system to give a point diagnosis in the case of congenital heart diseases, because it's like really tough. So you can put a basket of complex congenital heart disease, but your findings should be going hands in hand with that. That's very important. So before going into practicing any stations, it is very important to know about the domains in which you are assessed. This is very important in all the stations which you are practicing. You should know what all domains are to be like you are marked, so that you do not miss that domain. Because if you miss that domain, you won't be marked. You will be marked below standard in that. So this is very important. So when you are attempting your clinical station, be sure of knowing what all domains you are being assessed of, and you do not miss that domain. So in the case of clinical stations, there are 4 domains in which you are marked. First is the physical examination. So it should be like the way you perform it. It should be well structured. It should be like a systematic approach is very important. And you are taking care of permission of the, like you are asking the patient before examining. Those parts are coming in that. And you are using the appropriate instruments which are available there to do the examination. That is very important. Like if there is a hammer put there, so it has been put for some reason, you have to ideally use that. So based on your examination technique, how you are performing, you are being, and this is being assessed while you are doing the examination. So this is marked. So you are marked as 2, 1 or 0, depending on you meet the standards, either you are borderline or below standards. So second thing which you are being marked is the identification of clinical signs. So while you are doing your examination, you are doing it in a very structured manner, but you are unable to pick up the clinical examination. It's not that you won't be able to pick up all the signs. You might be able to pick some of them. You might be like so, and you might not be able to pick a few of them. So it's not that you won't be marked, like you will be marked directly 0 in that. If you are able to, if you are missing some of the points, and you are able to like identify some of the critical signs and symptoms, at least you will get 1 mark in that. So this is very important. Don't think that if you have missed something, you have missed the murmur, you are unable to make it, then you will be like marked 0 in that case. So you will be marked appropriately for that. Like at least you should get 1 in that ideally. So once you have identified the clinical signs and your physical examination is done, then comes the viva part in which clinical reasoning will be there. So in the case of clinical reasoning, the findings which you have got and you have identified those your finding, how are you interpreting it? Are you able to make appropriate differential diagnosis out of it with the findings which you have got? And do you really understand the implications of the thing? Like you are getting a pansystolic murmur, you are saying that you have got a pansystolic murmur and you are talking of PDA. It means that you do not understand the importance of your findings. Okay. So those things should go hand in hand. Whatever your findings are, you will be giving your differentials based on those findings of yours. And you should be able to suggest an appropriate steps if examination is inconclusive. So many times you won't be able to make the conclusions while you are examining. So in that case, there should be like you should be able to suggest appropriate steps, what should be taken, like additional tests which are to be taken, which will help you guide in your coming to diagnosis. So that's also important. So everything should be like in set pattern. It's not that if in your examination of 6 minutes you will are expected to give everything. So you will be expected to have a reasonable and it should be like going in hand with your findings, and it should be like appropriate. And then finally comes the management planning, which depends on case to case. In the case of cardiovascular system examination, the management plan is very important, that you will involve the cardiologist in multidisciplinary team. Cardiologist has the main role to play. That's very important. Second thing is like in universally, in addition to the routine tests, you will be doing 3 specific tests, which is chest X-ray, ECG and echo. So you should be able to know the findings which is expected in the what you expect in the case of X-ray, ECG and echo. That's very important. Don't just utter these things, because the examiner will invariably ask you what is your expectations in this. And you should be like putting on relevant investigation. Don't just give them a battery of tests, which is the tests which are needed for that particular test, like coming to diagnosis, that is important. So this is the way in which a clinical domain is marked. Hope the things are clear till now, right?
Yes, yes.
Yeah, that's good. So now we'll be like going to practice the first station, which will be clinical. So one of you can volunteer exam going people.
Yes, sir. Can I do it, sir?
Sure, sure, sure. Sure, Dr. Tanushri. So let me start the timer for you, because you will be entering into the clinical session and you will be starting for that. You have 6 minutes for that and 3 minutes for the examination discussion part. I'll just put the timer for you. So you are ready, right?
Yeah.
Okay. Okay. So you have entered into the clinical station and you have to examine the cardiovascular system of this 10-year-old boy, Ali.
Okay, so I enter the station, sanitize myself, and take permission. So can I examine Ali's heart today?
Yes, yes, doctor.
Okay, thank you so much. So I take a look around. How does he look? Does he look in distress, or is he well?
No, he doesn't look distressed.
And are there any devices around him?
No devices around him.
What about his dimensions?
He looks appropriate for his height and weight. He
Any
looks a
dysmorphic
bit thin,
features?
but yeah.
Any
Uh,
dysmorphic features?
no dysmorphic features.
Okay, and okay, I start from his hands. So in his hands, do I notice any clubbing or any? Okay, so I can see clubbing. Any signs of stigmata of infective endocarditis, like Janeway lesions, osseous nodes?
No signs of infective endocarditis
Okay,
in the
so
hand.
what about his pulse?
The pulse rate is 90 per minute, looks good in volume, and it is regular.
Any radial delay?
How did you look for it?
I will check for both the hands. I will check for the pulse and both the wrist and see whether there is any delay. I'll check.
No obvious radial delay.
Okay, and I will then check. I'll check for his BP later. What about his pubertal staging? About his axilla? Does he have any? Does he show any
Yeah.
hair?
Yeah, he has like stage 3 hairs, pubic axillary hairs in it.
Okay. And so after that, if I come down from the eyes, does he have pallor?
So this is what he looks like. So he doesn't have pallor per se.
Pallor icterus.
No express.
Okay, and then I can see that he's centrally cyanosed. And what about his dentition? Is it fine?
Yeah, it looks fine, and oral hygiene is also good.
Okay, any chance, anything I can appreciate in the back?
Sorry.
Any shunt backside?
No shunt, no shunt. You are seeing in the neck.
Yeah,
And
no, yeah, and
nothing.
if I come down, what about his carotid pulse and cavity?
There are no involved veins per se, and no involved vein to per se, and carotid pulsations are, you can palpate them. They look good in volume.
Okay, okay, and okay, I would now ask him to take off his shirt and keep
Okay.
him in a at 45 degrees angle. Ask him to lie down and do an inspection, 360-degree inspection all around from all the sides. Yes, I can see a posterolateral scar that is on the right side.
मतलब मेरा पसंद का कोई नहीं है लेकिन ये
And
कि मैं लंदन
what
में
about the
जाकर
back? Is there any kyphosis scoliosis?
बस यही
No kyphosis, no
अब
scoliosis.
mindset उसकी वजह से
That's
कभी
very
दूसरी कहीं
disturbing.
जगह किया नहीं
Chatting. Can you
यार
stop?
वो मेरा वो नहीं है कि
I'll just
लाजमी डॉक्टर ही हो पहले
Okay. Yeah, you can carry on.
So you said no kyphosis scoliosis, right?
No kyphosis, no scoliosis.
And anteriorly, no. Other than this scar, any other scars anteriorly?
No scars anteriorly. This is the only scar.
Okay. Okay. So then I finish with my inspection. What about the precordium? Any pulsation? Any hyperdynamic apex?
Okay, you cannot make out any like pulsations or any hyperdynamic apex. Like you can't see anything particular.
Okay. So I put my hands on both sides of the chest and try to locate the apex. Where is the apex?
It is located in the fifth intercostal space in the right side of the chest, and it is just medial to the midclavicular line.
It's located on the right side of the chest.
Right side of the chest, medial to the midclavicular line, fifth intercostal space.
Fifth intercostal space. Okay, so there is gastrocardia. Immediately, I also look for the location of the liver to see whether there is situs inversus.
Liver is on the right side only.
Liver is on the right side only.
Liver is not palpable. How have you seen for liver?
Yeah, I've tried to palpate it down from the right iliac fossa to look for the lower border of the liver.
It's not palpable.
It is not. It is not palpable. And what about on the left side? Since he has dextrocardia,
It's not palpable from the subcostal part.
the liver is not palpable on the left side also.
From both the sides, it's not palpable.
Okay. So I would proceed further with the examination. After finishing this, then I'll look. I will feel for any thrills, any heaves in all the 6 spaces in the apical area.
Okay, no thrills, no heaves.
No thrills, no heaves. Okay, and well, then I will. What about in the suprasternal and in the carotid area? No thrills anywhere?
No thrills, no heaves, no pulsations.
No pulsations. Okay, so next I will go for auscultation. First, I will auscult in the apical area, which you said it was the left fifth space.
So this is the auscultation findings, including the hard sounds and the murmur. And you are getting this on the right side in the second intercostal space, this murmur. Your time is over, actually.
Okay, time is over.
Okay,
Okay, at least the murmur findings.
Okay, we'll discuss it. You can just summarize your findings.
Yeah. I wanted to know the murmur, the findings of the murmur.
If you want, I can just show, but your time was over anyway. I'll just give you the murmur.
Will you give me the sound?
Can you hear?
No, I cannot hear.
Others are able to hear the murmur?
Not audible.
No.
It's not audible, sir.
Okay, okay. I'll just try once more. Can you hear it now?
No, sir.
Not now?
No.
Just a second. Can you hear now?
No.
No, sir.
I don't know what's happening. Internal sound can't be sure. I'm sorry, I don't know what's happening. I can
Can you share it? Can you share it in the group, target group? So at least.
Yeah. Just a second. I'm just sharing it in the group. Just a second. Where is it? Where have I put it? Just a second. Did you people get it? Okay, I have just sent it. You can hear just and then we'll continue. I hope
Okay,
you all got that, right? Yeah. Okay. You can hear that and then because your time is already over.
Yeah, I can hear. I can see that this is a.
Just a second. You are going on to the 3 minutes of discussion.
Yeah. It is.
Let me restart 3 minutes. Hi. You can now summarize your findings.
Yeah. So today I got to examine 10-year-old boy who has features of clubbing with cyanosis and mild pallor, and he has no stigmata of infective endocarditis. He has a murmur which is present in the right second intercostal space, which is a continuous kind of murmur. I could not appreciate radiation to any other part, and it is of around grade 3 because it is not associated with thrill. And to complete my examination, I would also like to check his full limb blood pressure and check his JVP and oxygen saturation. And he does not appear to be in failure.
Okay. So based on your findings, examination findings, what are your differentials?
Differentials is it could be a complex cyanotic heart disease in which a shunt operation was done, but it did not completely relieve his condition. He still has cyanosis, so probably corrective surgery has not yet been done in his case. And this murmur that I'm hearing could be of the shunt itself, and it could be also a shunt of aortopulmonary window, and
Okay. So do you, yeah. Do you expect cyanosis in the case of aortopulmonary window?
If a window, if it had been done successfully, the cyanosis should not have been present, but it is still there. So he needs further corrective surgery.
Okay. So how will you like to investigate this case?
Yeah, I would like to first plot his weight and height on age
दिखाना
appropriate
चाहिए मेरे को
chart,
क्या?
then check his
लीजिए।
vitals along with his blood pressure, whole limb blood pressure, and do ECG, Cohen, and X-ray initially, and take the approach this case under the umbrella of a multidisciplinary team with my consultant and the cardiologist on board, and corroborating the findings present in the investigations.
Okay.
And initially, if he is having this cyanotic spells, then treat accordingly. Give him fluids, give him oxygen, and other than that, could use some
Your
medications.
time is over, doctor. Okay, thank you. Okay. So, Dr. Tanushri, give your feedback, your positives, your negatives. You can
Dextrocardia,
improve.
actually, dextrocardia also is not something that I have done before. So
Yeah,
it was a little difficult for me to deal with the cyanotic heart disease with dextrocardia, and
right.
a shunt surgery being done, then
Right. Okay. So the good point was that for regards to diagnosis part, you could feel that it is dextrocardia and this is a complex cyanotic heart disease. Okay. Anything else? Your positive parts?
was the murmur the continuous murmur that I thought?
Your clinical finding of murmur was correct. That was a continuous murmur. That's good.
Yeah.
Okay.
And
You picked up the signs well. That's a good point. Positive.
was it of the shunt, BT shunt, the murmur?
Yeah, that was for the shunt only, because if you have a scar and you are getting continuous murmur, you have to put that as a differential. It can be any shunt, but yeah, BT is one of them. It can be any aorta to pulmonary shunt. It can be central shunts also. So your differential was a good point. Acha, what all you can improve on?
Maybe management part, and the other Viva part, I can improve on that, and maybe summarizing.
Okay. Dr. Tanushri, it was a good attempt. So others, I would like to get their feedback, both positives and negatives. Others, what was good in Dr. Tanushri's presentation and what was what can be improved? Feedback from others.
Hello. Yeah, she was thinking logically and proceeding in a stepwise, systematic manner, but a bit slow. And in dextrocardia, yeah, this was the good point about her. And she was moving quickly without thinking much. But in the drawbacks, it was like when it came to dextrocardia, she took a pause. She did not understand at that point of time how to check the liver. If you are not getting it, obviously if it is not enlarged, how can you get it? You cannot get that, so you have to percuss, I think, the upper border. That was the thing. And the
Correct.
other thing was BP cuff, BP, she said, I would like to take it at the end. Yeah, that was okay. So radial delay, she checked. In the end, did she mention that I would like to check radiofemoral relay as well, 4-limb BP? And I think saturations also, you have to mention that I would like to check the saturations as well. And one more thing, JVP, yeah, she told. And yeah, so yeah, so that was the thing, maybe.
Right, right. Points well taken. Any other feedback for Dr. Tanushri? Because we learn from each other's feedback. That's very important. So we should share our thoughts. What are the good
Sir,
points which we have to
I
imbibe?
have
Yeah,
a question, sir.
yeah.
Actually, I want to ask whether it is, if it is the case of dextrocardia, is it necessary to check for the livers, whether if it is not obvious, like
Hmm.
it doesn't change anything our management part, na?
Yeah, correct.
So we can offer it in the end.
See, what happens in the case of CVS system, ideally you have to see for the liver because signs of congestive heart failure are to be seen. It's not that you just have to make a diagnosis of situs inversus hai, yeah, isolated dextrocardia is there. Okay, now it's not a must. But if you are able to palpate liver and if it is on the left side, so you can make this diagnosis. So it is situs inversus totalis. But if you are unable to get it, so ideally, like if you really want to make it with, for which there will be no time, you are like percuss the upper border of the liver, so that is not needed, but you have to palpate for the liver because CHF is to be seen. So just try to palpate on both the sides to see if it is a case of dextrocardia. You should ideally see for both the sides to see if it is an isolated dextrocardia or if it is situs inversus totalis. Okay, na? Just because liver is a part of CVS system, that's very important for that.
Mhm.
So like on inspection, just after that we get that we are getting in a right side the apex beat. Just after that we have to check for the liver or doing the CVS completion and then doing the liver. Sir.
No, it's not needed to do after that because our aim of checking liver in this is not to make a diagnosis of situs inversus, right? We are checking liver in the case of CVS for the first most important thing, which is foremost important thing is to rule out CHF. Is the liver enlarged or not? So that is our primary aim. Our secondary aim is situs inversus if you want, if you have time really, for which you won't have. So our aim was that. So you finish your CVS examination of the precordium, I mean, and after that you can palpate for the liver. Don't get confused like you have to see for the liver. You are not going to hunt for the situs inversus, right? You have been asked to examine for the cardiovascular system examination. Okay, so that thing is very important.
And how does the areas change when it is dextrocardia? Like on the right side, what areas will be considered broad? There's a little confusion regarding that also. Like we know that the left second and left fourth and right, all these are aortic. And so what happens with the dextrocardia?
Right. Right. See, for all practical purposes, for dextrocardia, like there can be anything in dextrocardia. It can be congenitally corrected TJ also. It can be situs inversus also. It can be isolated dextrocardia. To make the thing simple, what you have to understand, the apex which is there will correspond to your mitral valve, right? The lower right sternal border in this case will correspond to your tricuspid valve area. Okay. The right upper sternal border will correspond to your pulmonary, whereas the left upper sternal border, you just invert the things, will correspond to your aorta. This is the way you have to just go for your cases because inside it can be anything. It can be aorta, it can be PA because there can be CCTJ also in the case of dextrocardia. For practical purpose, you have to just invert it and give your findings.
I mean, you mean to say the left second space will be the aortic area, the right second space will be the pulmonary area, and then
Right.
likewise, right? Just
Correct,
mirror
correct,
image.
correct. You're right. You're right. Absolutely. This
Okay.
is what I mean.
I was a little unclear about that also. So thanks.
Right, right. You for practical purpose, you just have to invert it. Don't confuse much in that because there can be anything lying inside. For that only we need echoes. So you don't have to indulge into that because that your investigations will give. So you just have to invert and give your findings. Okay. So with regards to my feedback for Dr. Tanushri, first of all, like her voice, see, in the examination, there are multiple things which have to be taken care of. Your voice and your confidence matters a lot. Even if you are full of knowledge, you are like following the approach. But if you feel like you seem like you are not confident in what you are telling, even if you are telling the right thing, it might fetch you less marks, because everything is like we show the marks, marking scheme and all, but it all depends on how is, are you really presentable or not. So that's very important. You should be very much presentable when you are giving your exam. You should show them that you are confident. So for with regards to Dr. Tanushri, her voice tone and it was there, feel like it looked confident, which is a good point for her. She entered into one most important point, which I'll like to tell her in the beginning is she's a bit slow in her examination. She has to finish the things within time. Because if you are unable to get the last parts of cardiovascular system examination, you might lose on important findings because examiner will not give you time. And if he gives you time, that's bad for you because your viva questions will be going then. Because it doesn't.
What do you think? Is that a good approach to finish the cardiovascular system first and then go for the supporting general? Because you need to find the findings of the murmurs and everything.
Right,
It's
right.
very
So
important.
once you have done your general examinations from your hand and neck, head and neck, go to the precordium examination, finish it fully. Both the sides you have to see. You got dextrocardia, see the back, do inspection, palpation, percussion, auscultation. Then only go to the liver and all. If you
No, I
don't,
meant why don't we finish the cardiovascular system, like the inspection and all that, and then go to the general examination? That will ensure that I'm not late in finding
see,
any
one
finding.
thing, Dr. Tanushri, one thing you have to keep in mind, cardiovascular system examination does not mean only the examination of the precordium. Cardiovascular system examination means examination of the cardiovascular system also includes your pulse, your clubbing, okay, your cyanosis. These are a part which you will not get in precordium. So if I am saying cardiovascular system examination, these are a part of it. When you are going to chest, that is called as precordium examination, not cardiovascular, because cardiovascular is whole. That's a GVP is also a part of it. Pulse is also a part of it. Clubbing is also a part of it. Seeing signs of infective endocarditis in the hand is also a part of it. Cyanosis is a part of it. So
No, I'm just saying about the sequence of examination. Like lot of our mentors, other mentors have also said that finish off with the cardiovascular system, auscultation, everything, and then go for the general examination. That is
refinement.
another.
Yeah, yeah.
So that's
This
what I was.
approach, this approach, I will not prefer anyone to take, because what happens, because many of your findings don't expect that you will be able to pick up the murmur. It's tough. In this case, you are able to pick up. It doesn't mean that we will be able to pick up in that tension of examination. So if you do not get any positive finding, or you are getting an ambiguous finding, and if you are unable to complete your general examination in which you have missed the clubbing and all those things, so you will be nowhere to give the viva, right? So it's always better to do that in a sequence, this general examination and then go to the precordium examination, because you will have something to tell. At least from this examination findings, you are able to tell, was it cyanotic or not, right? So you will be thinking of things which are in the cyanotic heart disease range. If you are examining the precordium first and you haven't seen the cyanosis per se, which is not very obvious, but clubbing was there, right, which you could not pick up initially in your precordial examination, in the last, in a haste, you could not pick up that mild cyanosis. So your diagnosis will go fully opposite, because your precordium examination, you might not be able to get all the findings with confidence at that time in that examination tension. So it's always preferable to go from the general to the precordium examination in the case of cardiovascular. And we have to make that habit of doing the things within 5 minutes. We have to practice them, keep on doing. Because if we make a sequence, it's easy. You will get more time. Okay, there is
Practically,
sufficient time.
actually, when you see things, it takes much lesser time. I have
Right, correct.
it
You are
takes
right.
than 4 minutes.
Very true, very
to
true. Because
complete.
you are not waiting for the answer, and you
Yeah,
are seeing and moving, seeing and moving. So it really takes less time during an examination. You are correct. So that is important. So that important thing was that you sounded confident, which was very good. And you should reflect that confidence throughout your examination and viva, even if you think that anything is going wrong, because that is going to fetch you at least 1 marks more. I don't know in which domain, but it will fetch you. That is very important. Second, when you entered into the room, did you greet the examiner? So ideally, you have to greet the examiner first, and then you are given a command, right? And then you will go and do your sequence of wipe, which we have discussed. So what Dr. Tanushri did was like she cleaned her hand, she introduced herself to the patient, which was very important. She asked for permission from the patient and the mother, if it is there, or the father, you have to take. And you have to, like previously in the like last session from till 2024, last diet, they were giving 2 marks during the examination, the way you talk and all for communication skills. Now they have changed it. So, but you have to keep on engaging the patient. You have to keep on talking to the patient. Try to engage him. Try to appreciate him for the things he is there. If you have to remove your shirt, just ask him, take his permission. And those things are very important. This is what is empathy. So keep on engaging the patient. Don't just think that it is no more marked. So you can't engage. It's better always to keep on talking to the patient and show your empathy. So the second part, then Dr. Tanushri moved on. She covered all the 4Ds. There was no distress, no devices, dimensions she asked for, and dysmorphic faces. Then she moved on to the examination of the general examination, which was there, in which she asked for clubbing, which was there, which was very good. Asked for the signs of infective endocarditis, which were not there. She asked for the pulse. She asked for radial delay, if it was there. That was good. Then she asked for the axilla, puberty, head and neck. She asked for pallor,
I
icterus.
have a doubt, just a moment.
Yeah,
At the time that we are seeing the pulse, supposedly if we get a radial delay, supposedly, so it's very
right.
important that at the same time you check for radiofemoral delay. But before doing that, is it important that you ask the permission of the examiner as well as also how do you go about that?
Yeah, that's very important. When you are going to palpate the femoral part, now you have to ask for the not the examination of the like examiner, but at least you have to tell the person whom you are examining and their attenders that shall I palpate him this side, femoral. You have to ask it for that. Because you are not
So,
doing anything extra, any instrument is not needed. You just have to palpate. But before palpating, always ask the permission of the mother or the father and the patient that I will be going to touch in this part for the pulse. You have to ask them. That's very important. You have to take permission. Okay.
yes.
So you covered your eye in that, you covered your mouth part. Very good. That's good. You covered your neck part. You asked for JVP, any distended veins, carotid. So this part was like covered in that. Then we moved on to the examination of the precordium per se. You examined on both the sides. You were able to pick up the dextrocardia wala part, which was very good. But in that part, after that, you wasted another 30 seconds, which was not needed to see for where the liver is and all. Left side, right side, upper border, lower border. You should not be concerned and waste your time. So that extra time, because you might get some bouncers sometimes during your examination. So you should not get deviated by those bouncers to other part. Okay. So you have to keep on your sequence. And if you are getting something positive, positive should be in that system. You cannot keep on examining all other systems, right? Finish your examination. Then if you want to confirm for situs, go for it. Okay, that's important. So other parts, inspection, you saw palpation, percussion. Did you ask for any like pulsations? You asked, right? Okay, thrill and all those things. And you could not complete your examination in time. So for the murmur. So murmur part was remaining. So that should ideally be finished. That's okay. And in order to complete your examination, you fixed up the things right. With regards to the summary part, your summary took almost like 60 seconds. It can be summarized a bit like with the positive findings. You just have to jot down your positive findings and tell them blah, blah, blah. That will save your time actually. Right. So you should be able to summarize a bit faster in that case. Okay. For management, go for the specific management first, which is needed in this case. So how will you confirm your diagnosis in this case? So that will be taking your X-ray, ECG and echo, which is very important, and cardiology involvement will be there. Because after that, you suddenly jumped into the management of spells, which was not asked from you. Okay. This child might not go into spells also, we are not very sure. So you should not suddenly jump into something which has not been asked for. Okay, because that wastes your time. The examiner must be going to ask you something else. So don't give your what you are asked is management investigations. Go for investigations, which will help you on what do you expect your findings in those investigations. Right. Then for the management, then you will take the help based on, it will depend on based on your examination, like cardiologist's opinion and echo findings. This is a complete congenital heart disease, complex congenital heart disease. You have to start from the management of like you have to see for, don't go into specific management, you don't know. So you have to see he's a cyanotic child. He should not go into like altitudes. He should not exert much. He should not be dehydrated. He should have prophylaxis of infective endocarditis. So those advice will also come in the management. Okay, that has to be incorporated. That is very important. I hope the things are clear to you, right, Dr. Tanushri?
Yeah, those advice I did not.
Yeah, it's not that they will ask you like with the heading of advice. Management includes these parts also, na. So you have to tell, you don't know the specific diagnosis, what is inside. So what you will say, he is cyanosed, you can see there is polycythemia. So you have to manage, tell him the management of polycythemia. He should not go in hot climates. He should not, he should avoid getting dehydrated. He should have infective endocarditis prophylaxis. He should brush 2 times. Those things are the things which you will advise him. That will come in the management. They won't ask you with headings. This is the way we like during our study and all we do it. So they won't give you specific headings. Okay. So the management will depending on the lesion. The management of other parts supportive, you have to highlight them in this case. Right?
So it is okay to say that the specific management will depend on the lesion,
Of
but
course.
general supportive management would include
Correct.
managing his hydration, and if and to avoid places of high altitude, to take prophylaxis for infective endocarditis, and dental care, all the advice that we usually give, right?
Right. Correct. Because you
And
cannot do the specific management. So that will depend on the findings and the cardiologist. Right.
okay.
Correct. It was a good attempt. Very good. So all the best for your examinations.
Thank you. So what differential diagnosis in this case? What should we think of?
So basically, you have to think of what you made. It is a complex kinetic heart disease. Most likely, it will be a decreased pulmonary blood flow because you are getting a shunt lesion, right? So shunt is normally done to increase the pulmonary blood flow. So you have a complex cyanotic heart disease with decreased pulmonary blood flow with a shunt lesions. The differentials can be TOF physiology. Okay, go for TOF physiology. It can be TOF, it can be DORV, VSDPS, anything. But it will be a TOF physiology. Those are having which are having a decreased pulmonary blood flow, right? Not Eisenmenger's physiology. Correct?
Oh, okay. So, how to
And your AP
differentiate?
window first, and your differential of AP window won't be sitting here. First of all, AP window per se is a cyanotic heart disease. Not a cyanotic heart disease. It is a cyanotic heart disease, first of all. Second, if AP window goes into Eisenmenger's, you will get the findings of Eisenmenger's, in which you will be getting signs of loud P2 will be there, pulmonary arterial hypertension will be there. Right. So those things you will get. So it will go more towards Eisenmenger's physiology. AP window per se is a cyanotic heart disease. It can go into Eisenmenger's, which can have Eisenmenger's physiology differential. It won't have decreased pulmonary blood flow differentials. Did you get me?
Yeah. So this can be any complex cyanotic heart disease, which
Right.
you've already
Right.
said. Okay.
Correct.
But
Correct.
after
Right.
the shunt operation done, still not corrected. So what can be the reasons for that?
So this is like shunt operation is done. Now they haven't done the corrective surgery.
Okay.
They have done the shunt lesion, and corrective surgery is to be is pending. Right.
Okay.
Any of the differentials of decreased pulmonary blood flow you can put, whatever comes in your mind. TOF, VSDPS, DORV, VSDPS, TGA, VSDPS, CCTGA, VSDPS, single ventricle PS. These are all complex cyanotic heart disease. So anything with decreased pulmonary blood flow, that is why they have put a shunt, right? Why is the shunt put? To increase the pulmonary blood flow. So they have put it. So any complex heart disease you have to put, right?
Yes. It can't be Eisenmenger, isn't it?
It cannot be Eisenmenger's, correct? Because you don't do a shunt lesion in that. And Eisenmenger's will have a loud P2. pH will be there, right?
Yeah,
So there will
loud
be a
P2.
very
Yeah.
loud P2. And they will
Pulmonary.
have, yeah, right, correct. And they will
And
have a diastolic murmur, mainly due to the PR.
okay, pulmonary regurgitation.
Right, correct. So let's move on to the second case scenario. This is a communication scenario. Who would like to take this? Any volunteers? Those who are exam going in the recent 1-2 months?
Sir, can I do?
Yeah, sure. Sure, you are Dr. Musab. Very good. So I'll just, before you start, Doctor, I'll just give you a brief outlook of like how you are marked in the communication station.
Okay.
So, see, for this communication station and for any station per se, I would again like to emphasize that the only thing which is important is practice, because your practice is only going to help you. Anything can go wrong on the day of examination, and you should be practiced so much that even if that is the worst day of your life, you should be able to get at least 62 out of 82 to make your day. So practice, and communication is the station which we need to practice most of the time, because even after repeated practice, we tend to use jargons, we tend to use some of the words which we use in our medical fraternity. So those are to be avoided mostly, except in the case when you are talking to some like medical student or your junior, then you can use those jargons, right? So what we will do, like I'll just give you the marking domain in this communication station also. You have like, you will have 4 minutes outside, 3 or 4 minutes, which is basically 4 minutes outside, in which you are given a stem, which you can read there. Then you go inside, you have total of 9 minutes in communication, which will be divided into 6 plus 3. After 6 minutes, you will get a bell will ring for you, so that you can now summarize in the next 3 minutes. Right. And you are marked in those 4 domains, the domains being you have to share the information and accuracy of information. So accuracy of the information is very important. They say in communication, it's not that you should have all the knowledge, but if it is a knowledge sharing one and you don't have any knowledge, then you can always tell in that station that, okay, for this particular question of yours, I am not very sure like what it is, or I have to discuss it with my colleague, or I will look into the literature. I need to read about it. You should be like correct in the information which you are giving. You cannot give any information which is coming to your mind, which can be wrong. And if you do it wrong, you will be marked below standards. So the accuracy of the information sharing is very important. If you don't have the idea, commit on that you will come back again, you will read about it, you will discuss about it, and then get back. That will at least fetch you marks. That won't give you a 0 marks in that domain. So that is very important. Communication skills, rapport and style is very good. So you have to make a rapport before you start speaking. And one thing always keep in mind, don't try to, we have all the structured like communication scenarios. We go through multiple books. We have like, we have to complete this. We have to bombard them with knowledge. This doesn't work. The most important thing is you have to give knowledge. That's a part. Information sharing is a part which will be marked only 2/8. The communication skills rapport will fetch you the another 2 marks, and you should always try to resolve the doubts which the patient has or the attender has. So if they are having a particular doubt, they are asking you for a particular thing which you think is not relevant. At that point, you have to at least tell them clearly that you will be coming to it, and you have to come back to it at the end of your communication. You cannot just tell them that you will be coming to it, or you have to commit that you will put another meeting in which this will be discussed. You have to give them an answer. Don't just try to finish off your agenda, because if the patient is having a doubt and you are not answering that, that again cuts your marks. The third domain is E2, in which verbal and listening communication skills are very important. There has been a general rule that in communication scenario, you speak a bit less, let the attender speak more. That is very important. So you are speaking less, let the attender speak more. If you are speaking 2 sentences, let him speak 4 sentences. Your sentences should not be long. So that is very important. Let them speak. You have to be a good listener also to fetch marks in this station. And managing concerns and agreement about the next step. Managing concerns, I was just talking about, and agreeing on the next further steps. Like if you are concluding the talk, so you have to agree on the further, like you will be giving some websites or leaflets, you will be talking about it, or another meeting which is needed, or you need to escalate the agenda to someone else. So you will be coming to some conclusion, and you should try not to abruptly finish the communication off. There should be some conclusion, and you should ideally summarize your things if there is time for that, or if you are dealing with a medical student, you should ask them to summarize the things for you. Okay, So these are the things which you should be like, see, these things are like structured format is there, but you will have to tune it based on your scenarios. That is very important, which comes only with practice, right?
Okay, sir.
So we'll go to the station. So I think Dr. Musab had volunteered. So I'll give you a 4 minutes, Dr. Musab, for this. And
Yeah.
then the time will start. We'll have 6+3 for communication station, right?
Yes, sir, sure.
Okay. This is your stem. Your time has started. After 4 minutes, I'll stop you. So, Dr. Musab, your time is over. You are ready?
Yes, sir.
Okay. Okay. So your time starts. You have entered into the room.
Can I start?
Yeah, start. Your time has already started.
Okay. So good evening. I'm Dr. Musab. I am working in the children's department here, and I believe I'm speaking to Sidra.
Yes, doctor. This is Sidra.
Hello, good evening, Sidra. Hope you're doing well today. Thank you for giving your time.
Yeah, doctor. Like, what should I tell? I don't know. Like, I'm really concerned about my son, Ali. Like, it was like
I
you had done
understand.
a few tests and I think the heart doctor also, you were telling that he'll come and see. Has he come and seen like what is going on? I don't know.
He, I'm here sitting here to speak to you about Ali itself, and what will be the probable diagnosis, what we suspect his condition to be. So, is it okay if we speak about it? And do you want anyone else to join you while we speak about it?
I'm alone, doctor. You can tell me about him, doctor, please.
Okay. Okay.
Is everything all right?
So Sidra, the thing is that what we have made a probable diagnosis based on the condition and the symptoms that Ali is having. So along with fever, he's having redness of eyes, redness of the mouth and surrounding area, uh, and I believe he's also having swelling in the neck. So all these symptoms they point us towards something called as Kawasaki disease. Are you with me here?
Yeah, doctor. I know about this disease, Kawasaki disease. Like in my ward
Right.
also,
Uh-huh.
in my ward when I was working in the last hospital, there I saw a child with
Correct.
Kawasaki, but I think it's something very serious, doctor. Is it really?
Right. Right. It see again the Kawasaki disease is a rare condition. What you have correctly said, and I should really appreciate you knowing the background of it. It can lead to serious complications. But the good thing is that we have made a diagnosis and we are involving the cardiologist. So after the cardiologist has seen today in the morning, he has suggested that, and he has done the scan of the heart, what we call as a study echo. He has suggested there is some mild dilatation of the coronary or the vessels or the what do you call as the pipelines that supply towards the heart. So there
Yeah,
is
doctor.
slight
Yeah, I
swelling
know.
on that.
Okay.
Yeah. So there is
Okay.
slight swelling on of that. So these all are suggestive of the Kawasaki disease. So
Mm.
are you here? Are you with
Any
me till here?
Yeah, I am understanding, doctor, what you are telling. But
Correct.
what I remember in that case, which I saw in my ward, I was telling you, like in my last hospital, they gave
Correct.
some, like they were saying some immunoglobulins, and the child
Correct.
really was like very bad. Like, what are you doing to do now with Ali? Like,
So
what's
the
the plan?
further management will be decided by the consultant in correlation and with consultation of the pediatric heart doctor also. So after that, what we will be doing is initially starting with something called as non-steroidal anti-inflammatory drugs along with IV fluids. And we might even need to give the IV intravenous immunoglobulins, which you have rightly said about. So that is also a treatment plan that comes towards the stages. So that these all treatment will help reduce the inflammation in Ali's body. It will reduce the pain, and it is a self-limiting condition. We do not know what causes this, but exactly. But the good thing is that we have picked up on what he might be having, and we have seen a lot of patients with Kawasaki disease and treated them. And please don't be scared. I know what you might have seen might be different, but Ali might react and have milder symptoms as compared to what children we have seen in the ward. So, are you understanding, Sidra?
Yeah, doctor. I am understanding. So you will be giving him, I suppose, IVIG as you told. And
Correct,
any
correct.
side effects of the it, doctor? Like Ali might have some like side effects from that.
Sidra, to be honest, even if we are giving paracetamol, it has some side effects, right?
Mm-hmm.
But any medication we are giving, we have to be we have to balance out the pros and cons and what will be beneficial and what will be harm. Will the harm be more if you are not giving? So the side effects of that IVIG might include nausea, vomiting, fever like chills and sometimes muscle aches. But these all things are not necessary. It is not necessary that it will come for Ali. These are seen in different patients, but we don't know how Ali will react. Might be Ali will have very mild symptoms, which will subside. Okay.
Hopefully so, doctor.
Hopefully, yeah. So,
And
is there
are
anything
you,
else you want to ask me?
yeah, 6 minutes over. And anything else like with this IVIG, like he will respond, like you have been talking about coronary arteries. Will they become normal after giving IVIG, doctor?
That is a very good question. Um, but see, better than me, the cardiologist is a better person to answer that question. So what I will be doing for that is after our meeting, I'll make sure okay and with it, we'll be setting up a meeting with the consultant and pediatric cardiologist as well. So they'll speak in detail about the heart and the coronaries. Uh, and we will be taking care of Ali with all the multidisciplinary team. I will, in the meantime, give you an information leaflet on Kawasaki disease and a website which you can read about it from, and you get back to me. Okay, if you have any other doubts, how does that sound to you, Sidra?
Yeah, doctor, I got it. Like you will give me some materials to read on, and then
Yes,
and like
yes,
cardiologist will be involving in this to sort of like I
correct.
have
And we'll
many
make
doubts
a
still,
sure. Sorry, yeah.
and yeah, I have still many doubts, but I think going through those leaflets and websites
Yeah.
will like help me in some way or the other, and
If
maybe
there are any
I would like
urgent
to talk.
if you have any urgent doubts, you can ask me still. But I think I've given the basic things. But still, if you have anything important, you need to know it now itself. Means you can please go ahead, or else
Yeah,
we'll set
doctor.
up a meeting.
I think for now you have answered my like questions which I like could think of. Of
I
course,
am
since he
happy
is
to
my
hear it.
son, you can understand I'll always have doubts.
You
I
can anytime you can call and disturb us anytime. You can We are there at the hospital. If I'm not there, my colleague will be there. You can ask your doubts anytime, even in the night. Don't worry about Ali. So we will be, as I said, we'll be involving the whole team, the consultants, the cardiologist, and the other necessary team will be involved. We will be taking care of his pain where and whenever necessary. Okay.
that will be grateful, doctor. Thanks a lot, doctor, for giving your time and making me things
No,
understand.
thank you, Sidra, for sitting so peacefully. So today we discussed about Ali's condition. What is the probable diagnosis that we think about Kawasaki's disease? And we have also told about the basic management, what we might be doing. And I've also told you that I'll be giving you some information to read from leaflet and website. And also that we will be setting up a meeting with the consultant and the pediatric cardiologist. So this was the
Fine.
gist of our meeting. Right, Sidram?
Okay.
So I hope I have answered most of the questions. If you still have anything, I am here, and hopefully within a few days, Ali will be fit and fine, and we'll be sending you both home. Uh, okay, okay,
Okay.
Sidram.
Time over.
Okay,
Already
thank
30 minutes excess.
30 seconds. Okay, sir. Thank you.
30 seconds. Good. Good attempt, Dr. Musab. So give your feedbacks. What are your positives and negatives in this? What did you find that you did well, and what you can, not negatives, what you can add on?
In initially introduction, I think I should have done better. A
Mm-hmm.
little better. The introductory part, greeting, and I should have asked permission of like, can I call you Sidra, or
Mm-hmm.
how should I address you? Something maybe this basic
Okay.
thing, sir. But you should tell me, sir, what I should add.
Right. See, your attempt was very good, and your like knowledge was good, and you did not commit on anything which you did not know. First of all,
Correct.
like I'll take the feedback of others, then I'll give you
Sure, sure,
feedback.
sure,
Right.
sure.
So others, please give your feedbacks, positives, and like what he can add on. There is nothing like negatives. It's just like what we can add on in our presentation. So give this positive findings which we have learned today, and give him add-ons from your side.
Sir, like in the introduction part, I don't know, is it right to say good evening, something like we are bad to say diagnosis? So shall we say just hello or something like that? A good evening, a good morning. I'm not sure, sir. Just a comment that we can
Sorry,
use this.
Dr. Priya, I didn't get you what you're exactly asking for. I didn't get it clearly.
Like just when we are introducing the patient or attendant, like we said good evening, good morning, hi, I'm Dr. Priya, something like this,
Okay.
just the introductory part. So if we are
Right.
about to say a diagnosis which is like not a good one, or
Mhm.
something like a breaking a bad news or
Got it.
thing like that, so
Got
is
it.
it right we say good evening or good morning?
See, you always have to greet them. That will be a part, even if it is a breaking a bad news, you have to greet them
Mhm.
first.
Right.
That's a part.
Okay.
Because whenever you start any communication, even if it is a bad news, breaking
Okay,
news, you
like
have to
saying
greet
hello.
them. That's very important. So that will be there.
Okay.
Okay.
And
You're saying in comparison to good evening, good afternoon, hello.
yes.
Am I audible? Yeah. So you are asking me, like, in cases of breaking bad news, instead of
Yeah.
saying like I am Dr. So, good evening, shall we just say them like hello and just
Hello.
start with the things? You want to ask me
Yes,
this?
yes, sir. Yes, sir. Yes, sir.
See, first of all, like, there is very important when you see the scenarios now, the scenario has different parts. You don't have to, like, you can see there is candidates information in which you are given the role. Okay, where you are talking to is also important, and whom are you talking to? So one point I will add in your question also, like add for Dr. Musab is like he did not confirm the identity of the patient. He confirmed the identity of the mother, but he has to confirm the identity of the patient. Establishing the identity is also important. Even if it is a breaking a bad news, you first have to identify the patient and the mother. So am I talking to Mrs. Sidra, mother of 3-year-old Ali? That's very important. He asked me, am I talking to Sidra? But Sidra can be multiple. So you have to confirm the identity. That's very important. Okay, even if it is a breaking a bad news, you will first introduce yourself. They should know whom they are talking to. Okay. And you should also confirm the identity. Then only you will go ahead, because you can be talking to someone else also, which can be a big deal, right? So that part will be there. I hope I made my point clear to you, Dr. Priya. So
Yes, sir.
you
Yes,
have
sir.
to tell them your identity, even in breaking bad news, and you should confirm the identity. That's a must part. Identity is to be confirmed, right? So that part will be there. Okay,
Sir,
good point.
also I
Any
think,
other like?
sir, like
Please tell.
sometimes, sir,
Please go ahead.
jargons were used. Sir, sometimes jargons were used, even though the mother is aware about most of the things, but still some jargons were used.
Correct. Correct.
And there were
Correct.
long
So the
sentences were
mother
used.
actually, yeah. So mother is aware of, what did you think that the mother was like doing? Why was she aware of the things?
So she said, like you said, in the
Yeah.
explanation.
Actually, she was a staff nurse.
Yeah.
Yeah, she was a nursing staff. Okay, na. So if you know after that, you can like take that part in your communication. You can just tell, okay, that's good that you know about it and you are like a part of team of this like nursing. So you have to just acknowledge it, that part also. And preferably, even when we are talking to nursing staff, except for doctors, we should avoid using jargons. Jargons can be used for like your colleagues and juniors. Prefer not to use much jargons even for nursing staff and other parts. Okay. That's what is needed. So jargon should be avoided even with nursing staff. That's an important point. Any other like feedback for Dr. Musab?
Yes, initially he said that, how are you doing? Instead of that, he could have said, nice to meet you. If you say something like this, that how are you doing? So you have to wait for the answer. So he just
Mhm.
summed up that thing on his own and then he moved forward. And for coronary artery dilatation, he could have used a drawing in order to explain it. What are coronaries? Nobody knows generally. And blood pipes was
Correct.
fine. He could have
Right.
drawn for better understanding.
Right. So in this case, points well taken. So ideally, if possible, drawing should be made, and he should made to like a simple diagram can be made, just that this is vessels which are supplying the heart. So these get like enlarged in size. So that's a point well taken. And second of all, if you ask any question, you have to wait for the answer. That's a very good point. So if you ask how you are doing, so you have to wait for it for the person to ask, because during your communication, I could see many times that it might be due to internet issue. I'm not very sure, but you were like interrupting the mother many times, which should not be there. Let her answer what you have asked for and let her come out. You should be speaking less, right?
Noted, sir. Okay.
Right,
Okay,
right.
sir. Okay, sir.
Good. Anything else from anyone?
Yes, sir. I think Dr. Musab has done a
Your
very good
voice is
job.
very less, doctor. Just we
Okay,
can't
sir,
hear you
I'm sorry.
clearly.
Can you hear me now?
It's better now. It's better. Please carry on.
Yeah, I think doctor did a very good job. But yes, I want to add on that there is follow-up prism, because there is multidilatation of coronary arteries. So along with that acute management, which he mentioned, NSAIDs, he didn't mention about aspirin and IV immunoglobulin. Along with that, we can talk about that echocardiogram. We will do a follow echocardiogram at the
Okay.
10 to 14 days and 6 weeks.
Right. Even if you are unable to comment on like exact duration when it is to be done, you can tell that in the
Yes,
follow-up, cardiologist will see, and echocardiography will also
will
be.
be done.
That's good. That's good. Because sometimes if we commit the times and if we are wrong, that puts a bad impression.
Yes.
That's a good point. Point well taken. So I'll add on my points for Dr. Musab. So almost all the points have been given by you people. So the good points are that he started with the things well off. First of all, the most important point feedback which I want to give you is like in one stretch, in the middle, you spoke just for 70 seconds continuously without any stop. So that should never be there.
Okay,
You
sir.
should not be speaking in that stretch. You have to ask the mother, is she
Okay.
getting it? Am I able to make
Okay,
myself,
sir.
am I able to make myself clear enough? Are we on the same platform? These are some of the words which you have to use. And it is to be used after every two sentences at least. So you should see if even if she is a nursing staff or anything, you should keep on checking. Is she getting the things or not? And you should never be like talking in a stretch. It will not give you good marks, it will cut your marks. So that thing is
Okay,
most
sir.
important feedback. Second feedback, Dr. Musab, is like when you have asked a question, you have to wait. This is what has been pointed by just one of the doctors now also. So if you have asked a question, wait for the answer, right? That's very important.
Okay,
Right.
sir. Okay, sir.
Third important points, as it was just told also, identity of the like the child and the mother is to be like identified. That's very important. It's the initial part. You have to confirm that Sidra can be anyone. So you have to confirm you are Sidra, mother of 3 years old Ali. So you have confirmed the identity. That is very important. Okay. Right. Third, last part mein in the last 30
Okay.
seconds, Dr. Musab, when you were talking, you just jumped on to summarizing the things because it was in the back of your mind that you are like running short of time. So before summarizing also, it should be made something like you have to cook the thing, like make it presentable. So I think we have discussed a lot and we need another meeting. Shall I just summarize it in a few words with you before we part today? So that should be asked rather than just jumping into the summary. The communication should go on smoothly. You are not
Okay.
like you have to complete every part, but it should
But
go very
someone, I was
sorry.
of the idea that some I don't know, some class I had heard you should not tell the word summary, that I'm going
Mm-hmm.
to summarize or something.
Mm-hmm.
Just so I don't know. So I was of that idea, sir.
Yeah, even if someone has told about you should not use the summary, avoid using that. So before we part today, can we
Mm-hmm.
just recollect the ideas which we have discussed today? Something like this you have to put.
Okay, noted, sir.
Ask her. You just
Correct,
jump
correct.
into summarizing the things because
Now,
it was
what's the
30 seconds.
ideology behind saying that we should not use the word summary?
This I'm not very sure of. Like I,
Why,
matlab, yeah.
why has anybody said that not to use the word? Is there any
That you
reason
should
behind it?
not, it should not be seemed, the examiner should not think that you have just mugged up a performa and you have come that you have to say this, and then in the end you have to say summary. You should summarize, but not use the
It
exact
can,
word
like, don't
summary, I
use
think.
that heading. Don't use that heading.
Ah,
It's also acceptable.
Okay.
Even I do not prefer
So we
saying
can
like
say
summary.
like, do you want me to conclude all the conversation right now we
Right.
had?
Yeah, you have to put something like this only. So before we part today, do you want me to just like jot down the points or just say those points to you in a few words so that we are all both are on the same platform? Something like this you have to tell, preferably. Right.
okay, sir.
So if sometimes they might say that, okay, doctor, it's okay for me. So that will save your time also, because the exam, see, what we are doing is a structured something. These are all from memory. We are practicing. Many times the role player there has been taught to tell something else. The role player has been told, okay, don't hear the summary, you just tell, okay, it's okay for me now. So that way will save your time also, rather than you jumping out of your time with summarizing the way you did. So that is to be avoided, Dr. Musab, right? You have to tell, said, okay, before we part, she might said, okay, doctor, things are clear to me. Okay, we can part. That's also good, right? So these are the points which you have to add in that. Okay. And the things are that you try to like give the reasons, like what the mother wanted, rather than giving all the information which was to be given. That's a good thing. You should satisfy the mother what she wants at that point, and the things which you were not deciding, you are not supposed to decide, or you don't know, you committed that those things will be decided by the cardiologist. That's also something very good. Okay.
Thank you, sir.
So I think these are the things, like, yeah, you did a good job.
Dr.
Just keep
Mehta,
on
I have a
practicing.
question. I have
Yeah,
a
yeah.
question. Can I have?
Yeah,
If
yeah,
you
sure,
finish
sure.
earlier, if you finish earlier, if you run out of time, that's obviously a negative point. But if you finish earlier, like 1 minute earlier,
Right.
2 minutes, also negative marking is there.
See, if you finish something more than 1 minute, it means that you haven't been able to like talk properly. Like you have been given this time thinking something, right? So if it is within 1 minute, you normally are not marked negatively. But if it has finished, like you are supposed to finish by 8 minutes is okay. But if you they have seen that, okay, the time is still there. So they are talking like that. You should not talk once you have concluded. So preferably tune yourself to that, that you finish your things after 8 minutes, between 8 to 9 minutes. That is the thing which should be like taken into consideration while you are practicing. Try to finish your things around like after 8 minutes. Don't try to finish it before 8 minutes, because otherwise you will be sitting in like seeing the examiner's face and the role player's face. So that doesn't put like negative marks in the case of clinicals normally, but or videos, but in the case of communication, you are losing on something. So it might fetch you a negative marks. So we should avoid doing that. So these
Okay,
things
thank
will come with our practice only. Try to practice between 8 to 9 minutes so that you finish it. Right. Don't try
Hi,
to
doc.
finish it much earlier also. That's very important.
Hi, doctor. Can I ask one doubt?
Yeah, sure, sure, sure. Doctor.
Doctor, actually, like 2 to 3 fever plus 2 to 3. So, is it a atypical Kawasaki? Because I heard that doctor was mentioning about the lymph nodes, which
Yeah,
was
yeah.
not mentioned in the scenario.
Uh-huh. This was the scenario. What are you asking? He had fever since last 1 week in the
Yeah,
scenario. It was around
he has
7 days.
rashes. He has redness of the eyes
Right.
and oral cavity. So he has three: the rashes,
Fever plus 3.
redness. Yeah, fever
Right,
plus
right,
2 to 3. So it is an atypical
right.
because
That's okay. Yeah, yeah. That's fine. That's
because
fine. Correct.
do we need to mention like because I heard that he was mentioning about the lymph node, which was not there in the scenario. Is that okay? We can mention.
This is a very important point. So good highlight. So we don't have to add anything from our side. That's very important. If lymph node has not been mentioned in the stem, we should not make it. Because if you are making something, you will be marked negative for it. Very good point highlighted. So
And
you should
one more thing.
add anything. Correct. Yeah, yeah. Please.
One more thing, doctor, like doctor was repeatedly telling, "Don't worry, mother." So, do we need to mention because mother, of course, will be worried about the kid. So, do
Mhm.
I need to? Do we need to mention about that in the
So you
scenario?
have to like see this Kawasaki with mild coronary dilatation. It is supposed to have a very good prognosis. Mother will
Okay.
be worried, but we are here to reassure her. We do not expect the prognosis to be bad, right? We expect the
Yes.
things to be good after we take care of the inflammation. Like if you are giving IVIG for decreasing the inflammation and there is just mild coronary dilatation, we are expecting the prognosis to be very good. So we need to reassure the mother because she's a bit tensed. So that part is also important. Had it been like massive coronary dilatation or aneurysmal dilatation, then you have to give it a balance. Like you can't just tell her that you don't have to worry. You have to take the things in hand like, okay, we are working on it. We are doing our best. You can't just tell that way. But this is mild. So we expect the prognosis to be very good. So we have to reassure the mother in this case.
Can I
Okay.
add on
Thank you,
something
doctor.
Yeah,
on this
please,
point?
doctor. Yeah, please,
Yeah,
doctor.
so I think we can rephrase the sentence like directly by no, we should avoid saying that don't worry, mother. Then we can say that I know that it's a difficult time for you, but yes, I appreciate your feelings or I appreciate your concerness. We are actually here to help you out. It's actually doesn't sound good if we say directly don't worry, mother. I
Yeah.
think
The
we can rephrase.
rephrasement is
We can
very important.
rephrase it.
Correct.
Yes.
That is very true. You have to rephrase the things in a like palatable fashion. That's very important. So those things needs to be repeated, practiced. That's very important. Your sentences and all will start coming when you have practiced lots. So like we have one more video. Anyone would like to take it? The last part of today's session.
I can take it.
Okay, Dr. Ryan. Okay, sure. So before going on to the video station, I'll just give you like how we are marked in this station. So basically in the case of video station, you have to sit outside the station. You don't have anything, no stem, nothing. You'll go inside the station. You will be given a video which will have a audio or have not a audio. So if there is a headphone, always use it. There will be a audio there. If there is no headphone, then the audio won't be there. And normally it is written in the outside stem will be given just that. You have to see the video, this thing, which is there, and there is no audio, they will be writing in it. The stem will write this only. So once you enter, you have to see the video for 3 minutes. It will be like you can see it in rolls. For 3 minutes, you have time, and then the discussion goes in the structured fashion in the next 6 minutes. Right. And the way you are marked is for the identification of the clinical signs, you are marked 2 points in which you'll be asked to summarize your positive findings. So you will be summarizing them. And then the clinical reasoning has second part in which you have to give your like approach of like what points in history you want to take. It should be relevant depending on your differentials, what examination findings you want to take in those case, what are the investigations, those that is very important. And management planning will fetch you another marks in which appropriate investigations which can take care of your differentials. And then management will be particularly asked giving you a particular diagnosis. A diagnosis will be given to you. Suppose that this is the case if it was not your first differential. So they will give you a differential out of your differentials. Or even if your diagnosis is wrong in video, this is very important. Even your differentials are wrong. In the management part, they will ask you, suppose that this is the case, what will be your investigations, what will be your management. So in this case, one good thing is there that even if you could not identify the clinical signs correctly, you will be able to get some marks in the management part, because in the management part they can ask you this question only when you know the diagnosis. So they will give you a thing. So suppose this is a case of this, how will you investigate or how will you proceed and how will you like treat it? Fine. So we'll see the video station. I'll just put this will run in loop. This will go for 3 minutes. I'll just give you, let me set the timer. So I have started your timer. You have 3 minutes. Your time has started, doctor. You can see the video, right? There is no audio in this
Okay,
video.
yeah,
No audio.
okay.
Your time is over, doctor. You can, like, if you're ready, you can start. Let me know.
Okay, I'm ready now.
Okay, let me put the timer. Okay. Okay, doctor. Could you see in this video?
Okay, I can see a baby in incubator in a hospital setting. There is no sign of respiratory distress and doesn't look cyanotic. There is a cannula on his right hand, and his heart rate is 160, and there is a discrepancy between the pre-ductal and postductal sats. The pre-ductal one is 100% and the postductal one is 83%.
Okay. So, what points in history would you like to ask in this baby?
Okay, so regarding the history, I would like to ask about his birth history regarding the mode of delivery. Is it a normal delivery or C-section or instrumental delivery? And what about the birth weight? And does the baby give an immediate cry? And what is the cause of the admission to the neonatal unit? Does the baby show any sign of respiratory distress at the time of delivery? And I would also want to ask about the antenatal history regarding the mom, if any medical condition throughout the pregnancy. And I will ask about the drug during pregnancy, a torsion screening, the virology screening, and if she is on any other medications.
Okay. And what would you like to examine in this child?
Okay, so on my examination, I will assess his vital signs, the pulse rate, respiratory rate, and sorry, the pulse rate already on the monitor. I would like just to count the respiratory rate and look exactly for the sign of respiratory distress. And I would like also to do a cardiovascular examination and if there is any murmurs in the heart, and I would like to do for-limb blood pressure and ECG.
Okay. So, doctor, based on your findings, so what are your differentials in this case?
Okay, so on top of my differential diagnosis, because of the discrepancy between the preductal and postductal, I will put the coarctation of the aorta, and on the top of my differential, and also other maybe other acyanotic heart disease, like maybe valve defect. But the coarctation of the aorta is the most likely diagnosis. And
What
also,
was
sorry, and also the coarctation of the aorta first, and then also the persistent pulmonary hypertension. It could be mild degree of BPHN.
Okay. Okay. And you said about acyanotic congenital heart disease also. Something you said, right?
Yep.
Okay. So there is a saturation difference between the upper limb and lower limb. And
Yeah.
you think that it will be a acyanotic congenital heart disease?
No.
Okay. Okay, doctor. So with this case, like, what do you like? How will you like to investigate this case?
Okay, so I would like to consult the cardiology to do an echo, and then depending on the find in the echo, we will proceed with the further management plan.
Any other investigations in this doctor other than the echo and involvement of cardiologist, which can help you
So
in diagnosis?
yes, uh, as I said before, I will start by the ECG, and then I will do chest X-ray, and then I will go for the echo.
Okay, okay. And how would you like to manage this case, doctor?
So, depending on the finding of the echo, and if there is like coarctation of the aorta, and if there is any cyanosis at any time, we can give the stabilize the child condition, and we can give also the prostaglandin, and then we can monitor the vital sign. If there is any drop in the blood pressure, we can give the vasoconstrictor medicine, and after that we can discuss further with the cardiology and the cardiothoracic if we need to do any surgery to repair the coarctation of the aorta.
Mm-hmm. Before coarctation of aorta, would you like to keep like differential of PPHN in this case, doctor? Above
Yeah,
coarctation?
we can. Yes, we can consider the BPHN, and that's depend on the echo finding regarding the pressure in the pulmonary vessels.
Mm-hmm.
So if there is any PPHN, we can proceed on giving the child giving the baby 100% oxygen, and then we will continue monitoring his condition.
Okay. And tell me your bedside test, which can help in this case of your first differential is coarctation of aorta. Which bedside test will help you in moving towards your diagnosis?
Uh, we can go with. We can do the echo as a baseline, but not the formal one, the other one.
Bedside test I'm asking about. Your time is over, by the way. No. So bedside
Okay.
test I was asking. Okay.
Sorry.
Okay, doctor, your attempt was good. Okay, a nice attempt. So you will first give your feedback, like what are your positives and where do you think you need like improvement?
Okay, so I think my positive thing likes I described the baby's condition well, and regarding his incubator and in the hospital setting, I think I missed some points in the history and in examination, and
Mhm.
also I don't think the surgery is. I should say the surgery, but it should be at the last thing because that's not my decision. That is the cardiologist's decision.
Okay, okay. So that was a really good point that you described the video very well. And you did not take more than like 1 minute in describing it because other parts of your Viva would, again, you have like 5 to 6 questions piling up. So you had time to answer them fully. That's a good point. So you described the video very well. Okay, okay. And any other feedbacks from our colleagues? Feedback from any one of you? What are the positives and what needs to like be added?
I have one remark and one question. Remark is that
Sure.
she makes baby looks well grown, term baby. Anthropometric measures seem appropriate for this baby. Doesn't
Good.
it? There is premature oxygen is not attached with the baby. That could have been mentioned.
Mhm.
Yeah, she mentioned. My question is, she told that pre-dectal and post-dectal saturation difference is there. I couldn't appreciate how the leads are like right and left going.
Right, right. I'll answer both of your questions first. So first point is like, see, whenever you are describing a video, it's very important, like आप clinical examination में what we do, right? We see the 4 DDDDs. That DDDD should always come out in our discussion of video. So video you have to talk about also, you have 6 minutes. So at least it should be like 1 to 1.5 minutes can go in the description of the video, and you should try to describe it in full. So doctor, you tried to describe it full, but like you can add all the 4 Ds as we see in examination. So you can tell about any dysmorphic features, how does it look like, what are the dimensions, devices, of course, you told. So those things will increase your description of the video and it will give you some more time to speak on, because many times in video stations what is seen with the candidates is that they are sitting in the last and they are not asked any question even though they are marked fully, because but it sometimes puts odd. So you can describe, you increase your description. Okay, so that can go. Second part is like you wanted to see the difference, you had this doubt, right, of like pre and post doctor. It's evident in the video, I'll just show it, just see. So after this neonate is shown, you just see they are marked actually. Here is pre, here is post. You can see they have marked it. Can you see that, doctor?
Yeah, yeah, yeah. Okay, so it's written over there.
So that
I
is
I
clearly
put it
evident.
posted.
because normally it will be marked. Otherwise, you won't know which is upper right. You couldn't see that. That's okay. That's okay. But normally it will be marked in the examination so that you know what the things are. Okay.
I mean,
Any
whenever there are two saturation monitors, doesn't it mean that one is of the upper limb and other is of the lower limb?
normally it means so, but if it is not marked, we cannot be very sure. Normally they will mark it. Okay. So if it is not marked, we can put that it seems to be one in the upper limb and lower limb, but I am not sure because it is not marked. You cannot take the things as implied, right? You can tell there are two which are not marked. Most likely, I think it to be upper limb and lower limb. The upper one of upper and the lower one of lower. Because you don't know really. It can be of two kids who are in the adjacent. So you have to commit this point that most likely it looks like that, but I am not sure.
Upper right limb and lower right limb, right?
Did you get my point? Yeah, doctor. Please tell.
Upper right and lower left, sir.
Yeah, and you are correct. No. See, understand the concept. Don't learn by the things. So why do we take the upper limb and the lower limb saturation? The basic funda is when your arch of the aorta comes off, right? The first branch which is given is the brachiocephalic trunk, which divides into the right subclavian and the right common carotid. This right subclavian is the first branch which is given off. So the blood which goes into this right subclavian from the brachiocephalic will be oxygenated, right? And after the duct, anything which is after the duct, where does the duct open? This opens after the third branch of the arch, which is the left subclavian. So anything which is near the left subclavian or below it will have something different. So it should be right upper limb and any of the lower limbs. There is nothing left lower limb or this. Right upper limb, any of the lower limbs. Right? This will work. Did you get my point?
Yes, sir.
Correct. So don't ratify anything. There is nothing to learn. Any of the lower limb will be supplied after the duct only because PDA comes much earlier near the left subclavian, right? So any of the lower limbs will work, but right upper limb because right aortic arch is left. The first branch which comes out is the brachiocephalic trunk, which gives the right subclavian artery. So you get the saturation. So okay. So with regards to the discussion of it, what is the differentials according to this? What are your differentials? You people can tell your differentials. What did you see in this and how the differentials are? You can put your thoughts. What do you think this condition is? And what will be your differentials?
It could be coarctation of aorta.
This is what the doctor also had put. Anything else before that, after that? She said coarctation, she said PPHN. Okay, anything else?
Any critical aortic stenosis or any duct-dependent lesions? Left.
Okay. Duct-dependent systemic lesions. Right. Yeah, correct.
Yes.
Okay, very good. So see, in this case, first of all, the most important thing in this case is to be seen is that the lower limb saturation is lesser, postductal is lesser than the upper limb. So in the setting history, you have to take the history, like you have to consider PPHN as one of the diagnosis. In this case, although it doesn't look to be distressed. So in the history, you have to take the importance, like history of meconium aspiration, meconium stained liquor, that is very important because it goes more in the favor of PPHN. Your first differential should be PPHN in this case. Whereas the cyanotic heart diseases which you are telling about, it will lead to universal cyanosis. If there is differential cyanosis in the case like this, what does it mean that why does the lower limb saturation get decreased in the case of cyanotic heart disease? It means that the blood is flowing through the PDA, right? If PDA is not there, you will not get differential cyanosis because PDA is the only structure which can produce differential cyanosis. And this PDA should be shunting right to left. So from the right ventricle, the blood should go to the pulmonary artery. And if the pulmonary arterial hypertension is there, if there is very severe pulmonary arterial hypertension, then only the RV blood will go into the PDA and the descending aorta and decrease its saturation, right? So it is a condition in which there is PAH invariably, right? One important thing which you have to learn from this is in the case of coarctation of aorta, I asked for one bedside test, that is pulse, lower limb pulsations you have to see for coarctation of aorta. You have to see for lower limb pulsations, which will be feeble or absent, right? So that helps in the case of diagnosis of coarctation. Second thing, in the case of coarctation of aorta, there is normally no saturation difference between the upper limb and the lower limb. There will be pulse difference. Basically, there is not so much difference in the saturation. Like it won't be going beyond more than 5 mm saturation difference. In this, you can see that it is easily around 15 mm difference. So coarctation of aorta, first of all, is a cyanotic congenital heart disease. It is not a cyanotic heart disease. So whenever you classify coarctation, it is a cyanotic congenital heart disease, and it does not normally lead to the desaturation of the lower limbs. Right. So coarctation should not be put as a differentials. You can put PPHN as your differential and other cyanotic heart diseases. If they go inside those cyanotic heart diseases, then you can say those who are having like increased pulmonary, which are having increased PAH. Right. Don't put coarctation as your differential in this case. Am I making myself clear?
Doctor, I have a question. Where is the baby cyanotic grossly?
Clinically, he is not cyanotic. Clinically, he
So
is
why
not cyanotic.
cyanotic heart disease at the top?
Sorry.
If we can. So why to say cyanotic heart disease at the in first place if he is not cyanotic?
The first differential which I had put is PPHN, which is what I am trying to say you. Put PPHN as the first differential because this happens in the case of PPHN, lower limb saturations will be higher than the upper limbs. Okay.
Yeah, that I got it. But
Right.
they are generally distressed. This baby is not. Still, we can keep PPHN as the top differential, right?
Yeah, you can keep PPHN because you are always keeping your differentials. This can be anything. So PPHN goes like if you are if someone is showing you such clear differential cyanosis, you should keep PPHN as first diagnosis.
Yeah,
Because
and
any condition. Sorry.
And second differential you told is cyanotic heart disease. So baby is not cyanotic.
Of course, but the lower limb saturations you can see now, it is like 85. So cyanosis can only be, one important point which you have to remember here is cyanosis can only be picked up by our eyes when the saturation is less than 85%. Okay. For this, for our knowledge purpose, I am telling any saturation which is between 93 to 85% is classified as a cyanotic heart disease, but clinically cyanosis cannot be seen in this age group, in this age range, in this saturation range, right? So for that, you will need pulse oximeter. There are a few cyanotic heart diseases in which the saturation is between 85 to 93%. Clinically, you cannot pick up cyanosis in those cases. The examples of those conditions being truncus arteriosus and TAPVC. They are not very much cyanosed because they have a good pulmonary blood flow. So the saturation ranges between 85 to 93%, right? So you will have to take the help of pulse oximetry to classify them as a cyanotic heart disease. So in this case, baby is not clinically cyanosed. Okay. So what can be the differentials based on the, see, you have to see not only the baby, you have to see the monitor also. Both, you have to see the full video and come to your conclusions. And you are not giving a diagnosis, you are giving differentials. So what are the possibilities seeing the whole video? These are the two possibilities which you can tell, right?
Right.
These only can be the possibilities. There is no other third possibility in this case. If there is differential cyanosis, either it has to be in the favor of neonate of PPHN. If it is a neonate, it is to be PPHN, or a cyanotic heart disease in which the blood of the PDA is going to the descending aorta, which can be anything. There is lots in that, right?
Blood of PDA going to descending aorta.
Right. So you have to make these as your differentials. Don't put coarctation as your differential. And for bedside test, coarctation, you have to see the BP and the pulses, lower limb pulses and the BP. right? Any doubts in this?
I have to see the BB and lower limb pulse or the lower limb saturation.
I didn't get your question, doctor.
The baseline, the bedside test is pulse, check the pulse, or doing the saturation in the lower limb.
It is the pulse. It is the, for coarctation of aorta, the bedside test is pulse, palpation of the pulse. Second will be
Okay.
the seeing BP. Saturation won't be different in the case of coarctation. Upper limb and lower limb saturation won't be different. Pulses won't be there in lower limb, or it will be feeble. BP will be less on the lower limb in comparison to the higher limb. These are the two things which you can say.
Okay.
So I think we'll conclude now. We have discussed 3 cardiovascular cases today. Hopefully it has been useful, and just to make you all remember that we are starting a long course from next month, from like around 1st of May. We'll be starting, and this will be going for the diet 3. It will be like we normally take, like it will be spanning over 6 months. In the initial 4 months, we'll try to complete every station in detail. And after 2 months, we normally prefer taking mocks. It will be like a lots of mocks practice is done in the last 2 months, around more than 20 mocks we do with our students. This will be a part of this only, this course. And you can just scan this and get access to our group for this. And you can contact us on the numbers provided for like this course if you are interested. So we'll conclude this session today. Hopefully it was useful for all of you.
Thank you, sir.
Okay. Okay. Thank you. Bye bye. Good night, all of you.